Hi, good morning, everyone. It's my distinct pleasure to introduce today's speaker, Dr. Roscoe Brady. Roscoe Brady is Associate Professor of Psychiatry and Vice Chair for Research in Psychiatry in our department at Beth Israel Deaconess Medical Center and Harvard Medical School. Dr. Brady is a man of many talents. He is a terrific clinician, and I have the pleasure of working with him in the early psychosis clinic called Aspire Clinic at Beth Israel Deaconess Medical Center, where we see patients together. And he is also a renowned researcher and has made some pioneering contributions to innovative treatments of serious mental illness like schizophrenia and bipolar disorders, in particular using neuromodulation techniques, specifically using a way of modifying brain circuits after identifying the circuits using imaging approaches. He is also a terrific teacher and highly sought after. And his presentation on the psychopharmacology of bipolar disorders was one of the most highly rated in our national psychopharmacology conference that we run every year. So today, he is going to speak on the diagnosis and management of first episode bipolar disorder with psychotic features. And he will tell you all about the science as well as the art of taking care of these patients. So without much ado, Roscoe, here, please.
That is a lovely introduction, and I will not live up to it. But yes, I'm very grateful for it. I'm very grateful for being invited. It's actually lovely to see familiar faces like in this audience. I will not get too nostalgic, for the sake of the people for whom this is not nostalgia. This is I came here to learn. I will not go on, but I'm very touched to see so many people show up and so many people I know. With that said, I'll go ahead and get started with some slides and disclosures, and then just basically I'm going to do the talk about what we're going to talk about aspect of the talk to help frame it. This very, very blank slide that's visible to everyone, things are looking good. Okay, great. All right. Anyway, so that's me, Roscoe Brady. I've been introduced. I don't have any financial disclosures, like no commercial interest. None of this is supported by pharmaceutical interests. Like I am supported by NIH grants, a very generous department that is my home, and very generous philanthropy from a few very kind families. Here's my outline for so two different things: outline for teaching goals, and then I'll get into an actual like structural outline of the talk. My thinking is basically I will talk for less than an hour and give us, a decent amount of time for questions and answers, like, at the end, like our discussion as it comes up. And my thinking is hopefully by the end of this hour, you can we can talk about maybe four things that have hopefully gotten better over the course of the hour. One is for people who are relatively new to basically diagnosing bipolar disorder, for students, for trainees on the call, and also for people who struggle with this in the clinic, which I do to this day. Maybe you've learned a little bit something about how to better differentiate bipolar disorder from other possible diagnoses in a way that really helps you pick medications, not just as an academic point. Second, and this is me, two things, meta commentary about what it means to be a lifelong learner, and also some actual practical things about picking medications, which is understand why it is if you are a good trooper and you actually pick up a review article about how am I supposed to treat bipolar disorder, with pharmacology. If you pick up two articles, you get two different answers, and if you pick up three, you get three different answers. And I'm going to try to try to explain a little bit why that is, why things can be so confusing. And as we do that, try to deliver something kind of pragmatic about what do I do? What can you do? And more importantly, what does the literature actually tell me in an actionable way? We will talk about treatments for bipolar mania. I want to say this, that part's going to be relatively brief, not because it's not important, not because it's not like a huge problem, but to some extent, I probably have less to say about it than many people in this audience. Or let me phrase it, whatever you were taught before coming into this like call, a lot of it's very, very true. And like I actually have not a ton to add to it, but I will speak to it a little bit. And then I'm going to change topics to basically talking about treating bipolar depression, which if you in this audience are working with individuals longitudinally in an outpatient clinic, right? Or you are an individual who is, a lived experience of this or any of these things, I think you'll probably recognize that is a very complicated struggle in terms of medication management and so on. So I'm going to try and probably end up spending more time on it simply because it's a more complicated issue. Okay. Um, Maybe one more thing I'll say before I get going with the organization. This is primarily a psychopharmacology talk. And so some of you in this call might have actually heard this talk. It's not very old, but I did give a version of this talk a few months ago at a continuing medical education class. The focus of the talk, of the class, was pharmacologic management of bipolar disorder. So one thing I want to say up front is a disclosure. I do not think bipolar disorder should be managed by pharmacology alone. Like, absolutely don't think it. I think the disease is too complicated and too dangerous, right, for individuals who live with bipolar substance disorders to uh, to treat it successfully with like intermittent medication visits. In truth, there are lots of people out there for whom that's the only care they can access, right? Like, and so you may end up in that spot. But it's my way of saying I'm going to focus on a bunch of medications here, not because I think that's the most important thing or the only thing, but simply because that's the stuff that I can put into, a discrete like 60-minute talk like this. But please, no one take away from me that I think this illness should be treated by meds alone. Okay. All right, so the organization, we'll talk a bit about family history as an aid to early diagnosis. We'll talk about navigating those treatment guidelines. We'll talk about, and this is, I think, a big one for me, how the chronic nature of bipolar disorder changes how I pick medications to treat. And then we'll talk, like I said, a little bit about bipolar mania. And then we're going to talk about bipolar depression. And for those of you who basically are prescribers, I'm gonna do something controversial and bad. I'm gonna focus on polypharmacy. I'm gonna make the whole talk about multiple medications for one individual, which is something that, like, I think in principle we should avoid. I think I was taught to avoid it, and in actual practice, like actually in like the clinic, if you're a prescriber, it'll happen. And like, I really wish people had taught me more about how to do that in a smart way. And so I'm going to try and my life is trying to correct that deficiency. And so for myself, hopefully it's useful to you. Okay, family history as an aid. So how can we diagnose bipolar disorder in the setting of comorbidity? And so you all know, for anyone who prescribes here, works here, has a lived experience of basically of a bipolar, like manic episode, like, there is bipolar disorder that's diagnostically unambiguous, right? Like someone walks in and they have a family history of bipolar disorder. They have the first manic episode. You're meeting them for the first time where you practice on an inpatient unit. I guess I would say that yes, there are a few things you need to like rule out, right? Other causes, causes of mania. But at some point, once it's ruled out, okay, you can comfortably say this person, it looks like they have bipolar disorder based on everything we're seeing, and that's how we're going to treat. I would say, as someone who practices mainly in an outpatient setting, I wish for that kind of clarity, because for me, much more often is basically I end up with someone coming in where they describe, the fancy term for, subsyndromal symptoms, right? They describe, hypomanic-ish symptoms. None of them last long enough to call it a hypomanic episode, or they describe a night of not needing sleep, but that only lasts a night or two, and just unclear what's going on. And it's also unclear because maybe they're getting treatment. If they're sitting with me, that means there's probably treatment in the picture. So maybe the episode would be much worse, except we've kind of caught it. We've ameliorated it a little bit. There are other things. So comorbidity, right? Like just the contributions of substance use, of comorbid anxiety disorders. Often when I sit across from someone in an outpatient setting and the question is it bipolar disorder? It's not clear at all. Like it's multiple things, or it's maybe something on its way to bipolar disorder, or maybe it's partially treated. And I find it very hard to try to like make decisions about, do we prescribe a mood stabilizer and have someone work with all the side effects involved with mood stabilizers, because I think it really is like bipolar disorder, or do I think it's something else, like some sort of like distress intolerance, emotional dysregulation? Should I be thinking in a like maybe a totally different direction, like maybe even prescribing an antidepressant? This is one of the few settings like I've seen in the clinic where actually like a really thorough family history helps, and actually helps me decide about a medication. Always good to take family history, but it's not that often that tells me how to prescribe differently. And so my one little bullet point about this would be this: bipolar disorder, right? Like in schizoaffective disorder as well, amazingly heritable. Like, so on this particular slide, they put it right at the top in terms of just how much the risk seems to be passed within families, and almost all of that within family risk passed genetically, right? It really is something inherited, like, basically at fertilization. Um, it's my way of saying that it is so strikingly so. And also, if you actually, putting aside the genetics, if you simply do the epidemiology and you ask for a person we know has bipolar disorder, what's the likelihood that they have a first degree relative with bipolar disorder? In most studies I've seen, a majority of people have a first degree relative with bipolar disorder, which is actually not true for schizophrenia, as an example. It's my way of saying, right, that in the setting of that kind of ambiguity, sitting with someone who has symptoms, we're not quite sure it is, I start to take a really thorough family history, and like what I'm looking for, right, is someone with bipolar disorder, right, or I would guess I'd say some other psychotic disorder, like a related disorder. It may be in a first degree relative. Usually it's not. Usually I hear a good story even before a person comes in about my father has bipolar disorder. But almost certainly what I'm really looking for is cousins, uncles, grandfather, grandmother, people where we're not sure what the history was, but they were institutionalized in an early age, and we're not sure what happened, but definitely some sort of chronic mental disorder. I do really try to plumb the depths to find that. And my point being, when I'm on the fence and I really can't tell which way to go in terms of like prescribing, if I hear a story like that, like, yes, like it's 22-year-old substance symptoms, and also there's an uncle who definitely has bipolar disorder, it will actually help me tip towards the direction of, let's start prescribing for you as if you have bipolar disorder. Like, let's talk about lithium, let's talk about valproic acid. And if we really go through all the possible cousins, brothers, everything, grandparents, and I don't hear anything about psychotic disorders, bipolar disorder, that actually will tip me a little bit in the other direction. Is, let's think about what else this could be that presents in a way that like looks like bipolar disorder or dysregulation, but I'm not going to go in the direction of prescribing like it's bipolar disorder. Okay. All right. That's my one diagnostic help for those of you who get confronted by like these, I don't know, these mysteries like in outpatient world. Um, Next part, navigating treatment guidelines for bipolar disorder. And like I'm gonna take you through like my personal journey of trying, like I said, trying to be a good student, trying to pick up a paper once in a while. Um, you know, I try to be a good evidence-based medicine clinician, keep up. There are many, 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 many treatment guidelines published out there, by many large organizations, right? So NICE, basically, this is essentially like the guide for mainly primary care physicians, GPs, general practitioners across all of the United Kingdom. Basically, what is the consensus guidelines about how one should treat bipolar disorder, how you should assess for it, how you should manage it. I would say it's maybe some of the most evidence-based, like, kind of criteria guidelines you could imagine out there. And just to pick out bipolar depression, for example, you read this set of guidelines, and sorry for all the text on the page. It basically says, yep, if you've got a person in front of you, they have bipolar disorder, they develop depression, and you need to offer them a medication to treat this. They're very definitive. Offer them fluoxetine and olanzapine. So Prozac and Zyprexa combination, like I think the trade name Symbiox, I don't think many people use it that way, but that's it. Like that's first line. Or also you could do also quetiapine, like as monotherapy, depending on their preference. Again, very definitive, great. If I pick up a different set of guidelines, it's also like, contemporaneous, published at the same time, up to date online. How do you treat bipolar depression? first-line therapy, monotherapy, quetiapine or lorazepam. No mention of olanzapine at all, like no mention of fluoxetine, no lithium, right? Like for those of you trained the same time I did, like, notably absent. And yeah, different medications. You keep going, so Australia and New Zealand, like basically consensus guidelines for treating mood disorders, very much like the first one, but different countries. Uh, it gets even more different. Like they see their statement, lithium, first choice lithium, second choice mood stabilizers, lamotrigine, valproic acid, and if you're gonna go to like an atypical antipsychotic, second generation antipsychotic, quetiapine or lorazepam, and this is maybe the big point here. But to be totally honest, if there's a difference between these two things, it's really subtle. It's really subtle. So just pick what you think you can do from these. Like pick based on individual preference, tolerability, your comfort level. Like it kind of doesn't make a difference like which of these you pick. They're so comparable. These are all consensus guidelines written about the same time. Why do they have such different conclusions from each other, right? They're all looking at the same studies, really. And so I'm going to say the reason why is that these different guidelines, they come from very different places in terms of how they're treating. And this is going to be relevant to everyone on the call. Some of these guidelines are very relevant to you if you are seeing people for a short period of time. Like if you're seeing someone in the inpatient unit, if you're seeing someone in a crisis stabilization setting, you have a set number of a couple of weeks with them, and then you won't be following them as an outpatient. You may choose to follow some guidelines. For other people who are going to be taking care of bipolar patients over months, years, many years, you actually probably will follow different guidelines simply because some guidelines think of bipolar disorder as a series of mood episodes. Like you have a manic episode and you treat it, and then later there's a depressive episode and you treat it, and then maybe another manic episode. And there are other guidelines that don't think of bipolar disorder that way, rather think of it as a chronic, lifelong disorder, and symptoms come in different phases, but it is not like discrete episodes that you treat like discrete episodes. And so as a brief detour, I'm going to talk about that second part because I don't know if you can tell, but for disclosure, I am an outpatient clinician. And so that second part about like, yep, a long-term disorder, I should say it that way, and symptoms present very often and not in discrete episodes, that is my experience in clinics. I'm going to highlight a little bit of why I came to that conclusion, and then we'll get a little bit into like nuts and bolts of medications. But I come to that conclusion based on not my own personal experience in clinic, but a number of studies, right? And so one that I think may be very, very, very relevant to this particular audience, people thinking about first episode psychosis, mania, and so on. So a long-running study, that got published, I think this is a 20-year-old paper actually, but people have done follow-up studies since then. I know there are people on this call actually like were maybe a part of this, looking at people, actually, let me back it up. People who bipolar disorder came on either so unexpectedly or so, basically management was not successful at keeping someone out of the hospital. They're in the hospital for their first manic episode. They get treated to a period of at least either wellness or getting to a point of no longer need to be in the hospital. They're discharged and they're followed up afterwards. And the question being, what happens to these people after discharge? What you see is this, following out over 2 years. And again, sorry for all the text on the screen. You're going to have all these slides available to you to download whenever you want. Some of them are very verbose. I mean it that way. So it'll be a guide to you in the future if you ever want to look back, but I'm not going to read everything up here. The brief summary, you look out over 2 years after the first manic hospitalization, almost everyone had a period where they didn't meet criteria for like a mood episode. It's striking that like 1 in 50 people absolutely did not reach that. Like they went from mania straight to a depressive episode that continued the whole 2 years or back into a manic episode. But almost everyone managed to get out of like what was like a DSM criteria episode. Fully 40% basically we're right back into another mood episode within just the 2 years of follow-up. And this is the third part here is the part I think is probably speaks to my experience the most. A third of these people had significant mood symptoms the entire 2 years. And what do you mean by significant? What I mean by significant is for a prescriber, if this person came into your clinic and described this level of symptomatology, like depression, hypomania, what it is, you would feel the need to act. Like, whether it be changing medication dosage, like basically changing frequency of therapy, adding on like, an individual, like outpatient programs that they weren't already in, you'd feel the need to act. A third of people had that experience the entire 2 years, right? And I'm going to say the most sobering part of this for me is a minority of people ever got back to where they came from functionally, right? So if you look at all these people before that manic episode in terms of, do you live alone? Are you in school? Are you employed full time? Manage your own finances? Like really like the key questions. You look at that before that manic episode and look 2 years later, only 40% got back to where they were. And that to me is like the end, very sobering, very sad. And another point not really mentioned in here is bipolar disorder to some extent is like when you think about functional outcomes, the place where people are 1 year after that diagnosis, a majority of people, they stay there, right, for years and years and years afterwards. Not everyone, not by any stretch, but something like 50%, that level of functional outcome after that first year, things don't really get better than that as you follow people out over time. This is my long way of saying that, like, it really looks like a chronic disorder. And it doesn't always have to be disabling, but for many people, this disorder who show up in our clinics, it's always there. Symptomatology, like, symptoms that are like really significant, present most of the time, quite a bit of the time. And it really has changed my conceptualization of how you think about episodes of just something that's constantly brewing, constantly there, constantly impairing. To maybe finalize that point, if you look out people who are a full decade into the diagnosis, right? So these individuals who basically are now they're like me, they're in their 40s. I'm 50 actually, so got to update the talk. But these people, like, it's not their first time at the rodeo at all. Like, so now we're not talking about a first episode of the population. It may not be relevant so much for this audience, but to get through it quickly, their experience over the next 2 years, basically, is strikingly similar, like 60%, like who are, people come in symptomatic, 2/3 of them actually do get to a period of some recovery, and fully 50% back in a new mood episode in the next 2 years, just like someone who's having their first break, right? Like really, like these episodes come at the same frequency, and to think about the symptomatology in between episodes. The average person in the study, the longest period they had of really being in remission, like a visit to your clinic where you didn't feel the need to make a change, 3 months, right? Not even a whole semester, like put together before the symptoms are back, and symptoms are back in a way that's really impairing, in a way that people really feel the need to do something about it. Okay, again, not first episode, but you can see now it really makes a case, right? This is something that is with people for a long term, right? And doesn't come in discrete episodes. So if I could pause, yes, the dry erase board is up and operational this talk, and I actually don't know if it's my job to fix that, but uh-oh. Sorry, give me 1 second. Okay, I'm gonna keep talking anyway. There you go. Thank you. How does current, so that's, like I said, a little bit of an academic point, but like, again, for trainees and audience, you may not appreciate this. For people who don't see outpatients for long term, you may not fully appreciate it, even though they're aware. How does that affect medication choice? So, like, nuts and bolts. I'm going to jump back. Some of those treatment recommendations that you saw at the beginning, they're entirely based on randomized controlled trials that are all short duration. They're entirely focused on the idea of, like, yep, the episode that we're in, how do you get someone out of it? Like, and we're going to fall out over 6 weeks or 8 weeks. And that's as far as we go. Some of the other guidelines are really reflect the longitudinal nature, right? Like, of the outpatient treatment. Even when you get remission with a medication or intervention, a relapse, it's, for most people, many people, relapse is only months away. All right, like, it is coming, and it's coming imminently. This is why you get guidelines like this, that basically are not focused on what is the best thing to get someone out of that episode immediately, but very focused on things like lithium, lamotrigine, and so on. And then basically antipsychotics, yes, valuable, which one, whatever, whatever is like, feasible, right? Because these guidelines are, they're really, really focused on tolerability. They're focused on what is a thing that can help someone out of the current episode and something they can stick with month after month after month afterwards, because the next episode is right around the corner, right? And we cannot have someone bouncing up and down with like a really effective medication and then it's intolerable, so it's gone, and now a new mood episode and back to another really effective and totally intolerable medication. That's how you get these different guidelines. That's how you get one person saying, oh yeah, 20 milligrams of olanzapine or 600 of quetiapine, that's the way to go. I'm going to say those guidelines are focused on very short-term treatment, and other guidelines are not, no, don't approach it that way. And focus on mood stabilizers and combinations of medications. And so, you prioritize tolerability, prioritize lower dose of medications. This is where you get to, as I said, polypharmacy, which is going to be a big focus going forward. Tolerable doses of one medication plus tolerable doses of another medication, or picking a medication that's medium effectiveness, but people can really stick with it, and supplement it with something else that's is effective, but you're not going to use the dose that is most effective because people can't take it over long periods of time. Okay. So now let's get to those medications themselves. Like I said, a little bit of nuts and bolts here. Medication interventions for bipolar mania, I said, relatively brief. As I said, for me, thankfully, this part hasn't changed much since medical school. For those of you in training, like in other programs, like since nursing school, pharmacy school, I think a lot of what you were taught is very, very true. And mood stabilizers, right? Broadly, they work to treat mania, right? Lithium can make a manic episode shorter and less severe. Valproic acid very much can do the same. Typical and atypical. Sorry, I don't mean to exclude, but basically antipsychotics as a class of medications, just about everyone ever tested, like all seem to make manic episodes shorter and less severe. Which antipsychotic is best? So I'm going to say, right, for treating manic episode, it is entirely dependent on treatment setting, right? Like I do not think randomized controlled trials have that much to teach us, because these medications all work. Or let me phrase it. They have something to teach you, but decision making is going to be based on where you are, by which I mean, if efficacy is paramount, right, and tolerability is second. So if you're in an inpatient setting, you have 24 people in a small unit, they're in close space, and some people are very ill, and basically, and are, what can I say? Conflict is happening. People like basically cannot keep themselves safe. Like you really might choose like a set of medications that are not particularly tolerable in the long term, but are maximally effective. And also, I'll say this, you really might choose to prioritize sedation, which in an outpatient setting, total game killer, like, absolutely like intolerable for like any of us, right, to stick with a sedating medication very long. In the inpatient setting, one really might choose that, like initially, simply because, like I said, safety concerns and trying to keep the situation safe as quickly as possible, right? If you practice in that kind of setting, the other thing to know is combinations of medications. So starting a mood stabilizer and starting an atypical antipsychotic, both within the first week or so, it is more effective than either one by itself. Episodes are shorter, they're less severe. Again, a thing you would not do, I think, in most outpatient settings, simply because of the tolerability. Okay, after the manic episode, so what do you want to do after that? Like once a person has been treated through a manic episode, where do we go from there? And how do you make medication decisions about discontinuing medication? So if you're working with someone whose inpatient experience was they're put on a combination of lithium and quetiapine 600 milligrams a day, and they're coming to you in that outpatient setting and saying, this is too much. Like I cannot function. What do you do? As a quick rule of thumb, you're going to make a change, right? Because if you don't make a change, then like change is going to happen. People cannot stick with these things forever. But what's the right change to make? So a couple things, right? And again, not news to many people. Lithium really does have, it really is effective, as prophylaxis against mania and depression. Not very effective at treating current depressive episodes. It never has been, but really does have some value at preventing the next episode. Valproic acid, a little more confusing, actually seems to really shorten manic episodes. But every randomized controlled trial ever done where they ask, does it prevent the next manic episode? They've all come up negative. And I actually have not seen one of those published in quite some time, but just a little bit strange. And like, I think I say worth noting as you're trying to think about medications to prevent an episode as opposed to end an episode. Atypical antipsychotics, as a rule for every single trial I've ever seen published, if someone takes an atypical and you name it, whatever it is, Abilify, Ziprasidone, olanzapine, like what, I'm sorry, I'm mixing trade and generic names. But if you name an atypical antipsychotic, if it helped get someone out of a manic episode, it will help prevent the next episode, just like as a blanket statement. Like everyone ever tested, they all seem to do that, right? If someone's never taken antipsychotic, it's hard to know, like if it'll prevent like a manic episode. The answer is probably yes. But if it helped get someone out of a manic episode, it will help prevent the next one more than discontinuing it. And also, as a general rule, almost none of them do anything to prevent a depressive episode. All right. So if someone comes off the inpatient unit, you lower an antipsychotic to a dose that is manageable in terms of like, people's tolerance of it, the side effects. They are better off when it comes to preventing the next manic episode, and it will probably do, like I said, very, very little to prevent a depressive episode in all the randomized controlled trials ever published. So you're going to end up having to think about something else, I think. A second thing here is if you're working with someone who did not respond to monotherapy in the inpatient unit, if you're working with a client who needed a combination of medications to get off the unit, to get to a safe place, like, lithium was not enough, or quetiapine is not enough. You had to do a combination of both. If the question is, should they continue in a combination? The answer is that is actually for that individual with that much treatment resistance in the unit, the trials really show that they are better off when it comes to preventing the next episode if they stick with both. That's a tall order, right? Like that's hard to do in an outpatient setting. But if if the question is it worth it? Is there some value? The answer is there is value preventing that episode, more value than like just one or other by itself. But again, same rule applies. Combinations also do not seem to prevent next depressive episode any better than just a mood stabilizer alone. So again, monotherapy with any of any of these antipsychotics, they leave depressive episodes poorly defended against, and that's going to be a consideration. We're going to talk about that. Maybe one exception, again, sorry for all the wordiness on this, but like if I can just very quickly say this, there's maybe one exception to that in the randomized controlled trial literature. The combination of either lithium or valproic acid plus like 600 milligrams of quetiapine, that combination actually does seem to confer protection against both mania and depression going forward, which is great, which is good to know there's something out there. But again, as I've said, that combination of medications really hard for people to stick with. The trials where they did this, like the retention rate, people completed the trial, it's really small, like much shorter actually than a lot of the other long-term treatment studies you've seen. So value to the combination, hard to do. Okay. So I just finished this part of the talk saying that, yeah, we've got some stuff that really helps for manic episodes. And also those things, they help protect against if you're thinking about someone in an outpatient setting, they help protect against the next manic episode. And I keep saying over and over again, they don't do much for depression. They don't do much for depression. So depression is going to show up in the clinic. And it is going to be a thing that is maybe, I think, much thornier to navigate than like manic episodes and so on. How do we do that? So everyone here can do a Google search for like randomized controlled trials for monotherapy for depression, right? And you can find, right, like here are the hits, and I won't go through all of them on this slide, but you absolutely can find like an RCT that shows that quetiapine works, and more the better, right? Not 50 at night, but like hundreds of milligrams. And olanzapine works, and lurasidone works, and again, more the better for something like that. Lumateperone, cariprazine, like yes, there's all these things have, you know, RCTs where monotherapy work. Maybe one thing, or maybe one or two things I just want to point out on this slide. It is not news to the people who've been prescribing for a long time that lithium really not very effective at treating depressive episodes, like maybe effective at preventing them, not all that helpful at getting someone out of a depressive episode. I think that's been known since lithium was first introduced, but the few times people have ever tried like a modern RCT just kind of validated that. Second thing in here, lamotrigine, I think of as like a real go-to, right, for like trying to treat a depressive episode. And also, I'm going to say broadly, in the population of people who live with bipolar disorder, it's been disappointing, like, you know, for me to see how effective it is at treating depression. And finally, valproic acid is a complete mystery to me because I don't think of it as being effective at treating depression. I know a bunch of other clinicians who don't think of it that way. And also there are a whole bunch of small, like really small RCTs out there where it's like wildly effective. I have thoughts about why that is, but as a take home, I would simply say that to me is a big question mark. And I actually am not, I'm really unsure about treating bipolar depression with valproic acid. Notably absent, like from this list of medications of monotherapy, I think are the ones that like, or at least one that we go to like all the time, right? So aripiprazole, Abilify, and geodon, ziprasidone, maybe not so much the geodon, but you know, I do feel like everyone with bipolar depression at some point we try to treat a depressive episode with these things. I have been roundly disappointed, like every time. I think it's always worth trying because, you know, honestly, if you can treat someone with a metabolically safe, easy to take medication and it works for them, thank goodness you tried, because they are a lucky individual when it comes to treatment. But it's hard. It's hard to find those people in my experience, and it's impossible for randomized controlled trials to find these people where these things are very disappointing as interventions. Okay, so this is my preamble to saying monotherapy, I think of it as absolutely the exception, not the rule. I think monotherapy for bipolar disorder is a thing that happens in papers like all the
I think I
time.
want to give a light explanation of what that's like being the schizophrenic patient and the current protocols and like the current whatever they do to determine what medications are delegated to what patients and why, and then start diving into the research, and then of course at the end tie that all together with of course I don't envision this going to be completely conclusive, but because initially I thought this was supposed to be conclusive research, but my understanding it's not.
But
I
it's
would like to eventually
Michelle, it's important, you know, it's super important. And also, I think you chose a very nuanced, difficult topic. So I'm very proud of you. I think it is gonna be good. The only suggestion I have is, so let me see, Monday is the 29th.
Yes.
So when is your paper is
Sorry, can I interrupt for 1 second?
I have to open the syllabus.
There we go. Sorry, for a second there, that seems like a very relevant conversation to this topic, but I think someone had their mic on. Okay. Anyway, I'm going to keep going. Where I was saying probably for the third time this talk, like, yeah, monotherapy, exception, not the rule, right? So like other studies that teach us about combinations of medications, I'm going to say fewer studies than I would wish, right? Like it is something where like it actually, there's a lot less out there than I ever would have imagined, thinking about combinations of medications that treat someone out of a depressive episode. To walk through a little bit that's out there. So this one, right? So a combination of the thing that was like number one on the treatment guidelines for that first like guide to prescribers, combination of olanzapine and fluoxetine. Yes, like that is a combination that does seem to work in multiple trials and so on. It's notable, right, that like basically this seems to be somewhat reliant on the fluoxetine, the Prozac part of this combination of things. I don't think I know many people who've really embraced this as a treatment simply because olanzapine is so hazardous in terms of metabolic effects and those kinds of things. At this point, right, we do have maybe one other option, right? So there's a combination medication of olanzapine and samidorphan marketed as Lyvalbi, right, which is not metabolically neutral, but is metabolically seems to be like much less, than olanzapine alone in terms of effects on LDL cholesterol, weight, and so on. So there is, I think, reason out there to think that maybe a combination of those medications plus fluoxetine helpful for bipolar depression, not as metabolically dangerous, right, as some atypicals on their own. But this is brand new, right? It's really new, and I'm going to say like the jury's still out. We will find out if that is a tolerable and effective treatment for bipolar depression going forward. So lithium and lamotrigine together, like so in individuals who basically, and you will run into the scenario, I think, who lithium has been a somewhat effective medication at keeping someone from the next mood episode, and then you see depression break through. What do you want to do next? You are thinking about an atypical antipsychotic or something else, but those are hard to tolerate. There is actually evidence that adding lamotrigine to lithium actually really does confer a benefit, right? They're not duplicating each other's effects. The combination together, probably one of the more tolerable things you can do in terms of combining therapies into polypharmacy and going forward. It's to me like a often at this point like a starting place if someone has a depressive episode that breaks through lithium as a monotherapy or treatment. The combination of lamotrigine, adding lamotrigine to someone who's just taking quetiapine, just taking Seroquel, also similar kind of effects of efficacy, right? A very, I'm going to say easily tolerated, if I could make a blanket statement, easily tolerated thing to do to add lamotrigine to a not so easily tolerated medication like quetiapine. And it really does help some people in terms of getting out of a depressive episode, like in a way that's validated by RCTs. Same thing for Geodon, Lorazepam. So now I'm starting to think things that are a little bit less tolerable than say adding lamotrigine, but still from a metabolic perspective, safe. Adding lorazepam, like to lithium, whatever the depressive episode broke through in terms of mood stabilizer, adding lorazepam to that really does seem to help treat a breakthrough depressive episode. And much more recently, right? So basically a combination of lumateperone, adding that basically to people who got lithium, got valproic acid, wasn't sufficient to basically prevent a depressive episode or get them out of a depressive episode. Adding lumateperone to it really does actually seem to be an effective intervention. These are now, we're getting into trials that are published 1 year ago. There's like one single RCT done. Your mileage may vary. I do think we're going to find out, like as a feel, like how helpful these things are. But I'd simply say I have my eye on this as a thing that like really, really could be helpful and nice to basically round out some of the other options you just heard about. Okay. Anyway, that is my talk, right? Like in a nutshell, like I'm hoping that in here we got to talk about like a couple different things to get back to the treatment goals. You got one tip that I didn't know about as a resident that I've kind of pulled into my practice when it comes to thinking about differentiating bipolar disorder from other diagnoses, really thinking about family history in a way that it actually has not helped me decide in terms of treatment for a lot of other diagnoses, but in this case, it has helped me a few times. You hopefully have gotten a little bit of an idea about why it is. If you read a few papers, things get very confusing the more papers you read in terms of thinking about different treatment guidelines. I'm suggesting here it's simply because some people think of this, or some people are treating bipolar disorder in short time frames, in 6-week setting, in an urgent setting, in an inpatient setting. And for them, one set of treatment guidelines might be entirely right. And those guidelines absolutely do not apply at all, to people who have to, you're taking care of someone, you're working with a client together over years, and tolerability is really, it's paramount, right, in that setting. You've heard a little bit about basically treatments for bipolar mania. I had very little to say about treating the manic episode because, again, I think I don't have anything to add to like the very old literature about mood stabilizers work and antipsychotics work. The only thing I think I might have added here is what you do after that manic episode, right? Like, it gets very complicated and very confusing because the things that get you out prevent manic episodes, but often, very often, don't do very much of anything to prevent depression. So like you can anticipate that coming, right? Like that's going to appear in your clinic, and you need to have a plan for what you're going to do about it, pharmacologically and non-pharmacologically. And finally, thinking about basically treating bipolar depression when those depressive episodes inevitably arrive in the clinic. You've heard my argument. Like, I do think, that monotherapy, it really is the exception. It's not the rule. And so knowing about a couple interventions that like really do seem to work, like combinations that are, let's say for the most part, like, yep, adding a tolerable thing to a not so tolerable thing, and not simply stacking more and more and more intolerable medications. There are combinations that seem to work that people really can't stick with. It is striking how few RCTs there are actually showing that. So a lot of it is probably going to be you figuring it out on your own, just like all of clinical care, right? Like, in 2024, but there's some guidelines, there's something out there to help you with these decisions. All right. And with that, I will stop my TED Talk, and I'll open it up for any kind of questions and discussions, anything like that. So thank you for listening and for inviting me.
Maybe we'll start with Alexander has that hand raised.
Yes, hi, I'm Alex. I'm a psychiatry resident at UMass. This is a really helpful talk. You may have touched on this already, but it's still very, I don't want to say jarring, that might be too strong, but provocative to hear a strong argument for polypharmacy.
Yeah.
In cases when it's like contrary to not just in psychiatry, but in every other place where I've rotated.
It's heresy. Yeah.
It might be heretical in some places, I'm sure. So do you and given how yes, you could better treat the depression, but you expose them to like toxic side effects. Do you ever attempt to try to peel off the antipsychotic in the once the bipolar depression is in remission, or once something has worked, you kind of just keep them on it because they're at high risk for relapse of bipolar depression?
Great question. So maybe here's what I would say. I really do view polypharmacy as like I don't know, necessary evil. I view it more as a upsetting inevitability than something to be desired. And so what you can do for that is, like I said, I think absolutely, obviously, try monotherapy, and please, by all means, try to find that person who only needs one easily tolerated medication, basically to absolutely thrive. Try it out, because if you can find that person who the nature of their specific illness lets them respond, what a lucky break, all things considered. Secondly, just as you say, when I think, and again, provocative, when I say inevitably, when like that doesn't work and you have to go to 2 medications, if you get someone out of that episode, so to get to your exact question, they get out of that episode, I do think, even for these medication combinations where I'm saying, oh yeah, this is a little bit more tolerable, adding lamotrigine as opposed to 600 milligrams of quetiapine, it's more tolerable. But I do think peeling off these things is, it's always worth trying. The clients you work with, who have to like basically, suffer these side effects, are either going to bring it to you, right, for discussion, or they're going to be thinking about it without telling you about it. And so I think it's really important for us to bring it up and say, like, yes, you are probably thinking about what can we peel off, and then exactly to get to that, yes, like if you hear, yep, that's what I'm already thinking about that. I think it's worth embracing that it's going to happen, and then try to do it in the safest way possible. And even as you're taking off that medication, absolutely have a plan B and plan C for reversing that or switching to a different medication, because it's, I'm going to say, somewhat likely that it happens. There's a whole other talk, maybe not a whole other talk, but I could spend a little bit more time talking about deprescribing as a real specific thing in bipolar disorder, simply because deprescribing on principle, I think, is always good. In bipolar disorder, the speed with which you stop these medications is a much bigger deal, I think, than it is in a lot of other scenarios, right? And I'll give you one very specific thing. If someone has been taking lithium, even for this really sad situation where lithium didn't help all that much, but they've been taking it for 6 months, a year, something like that, and it didn't help them, and you're going to switch it off. If you discontinue lithium abruptly, and by abruptly I mean someone just stops, or they stop over a period of a couple of days, that is much more hazardous than tapering it off over weeks. And even weeks is actually a little bit more hazardous than months. So I think yes, absolutely, you're going to deprescribe. You're going to go from polypharmacy back to monotherapy to see if it works. The way that you do that, like doing that in a really slow, controlled way, absolutely mitigates risk. And like I embrace it, it happens. And I always also have a plan B for like bringing polypharmacy back in when we find out that monotherapy isn't enough. I hope that's helpful. Sorry for the
Yeah, it
soapbox.
was. Yeah, thanks so much.
Michael, you're the next hand raised.
Hello. Is there something special about olanzapine combined with fluoxetine? How much do we know about combining a non-olanzapine atypical with a non-fluoxetine serotonergic medication, like another SSRI, for instance?
Yeah. Great question. Here's what I would say. If you ask me to bet, bet your life, Roscoe, like, is there something special about it? I would say no. Like, there's nothing actually all that special about it. It's one of these things that's it's waiting for some pharmaceutical company to like put its money down on doing adequately sized, or it doesn't have to be pharmaceutical. It's waiting for some funding agency to fund, like, and ideally not big pharma, a big RCT where we basically ask like some of these questions. Here's what I would say. That hasn't happened so much yet. If you look at those studies, like, of the combination of like, yep, where does placebo get you for treating bipolar depression? Where does olanzapine get you for treating bipolar depression? And where does fluoxetine get you? And where does the combination of two medications get you? I'm going to say that it actually, in those studies, it kind of looks like olanzapine isn't helping all that much. I think almost certainly, if it's doing anything, it is helping a little bit with depression. It is helping prevent a bad outcome of treating bipolar disorder with the SSRI. And the SSRI itself, which is normally not effective, basically in treating bipolar depression, something about it, the combination of that with like olanzapine, it seems that actually it helps more than it does as monotherapy. There's no way that can be, in my opinion, some sort of really specific effect. I think it probably is like, yeah, something about combining an SSRI with olanzapine, or maybe atypicals in general, but I don't know. Those studies really haven't been done. I feel like it cannot be fluoxetine specific, but again, all the evidence is really for that combination of olanzapine plus fluoxetine. And as I said, in my clinic, we are actually trying at this point so I'm not endorsing Lyvalbi as like the next thing to do, but that combination of olanzapine with samidorphan to basically treat the metabolic effects plus fluoxetine, I'm enough of a idealist that we're trying that out, and I'm lucky to have patients who willing to do that with me, and because they're the ones at the real risk, right? So far, so good.
Thank you.
I'll stop there. Yeah.
Also, can I ask a question? May have already been asked. I was out to the call for a couple of minutes. Thanks for a great review of psychopharmacology of bipolar disorders. A lot of the audience here are people who take care of people in the early course of psychosis. So the question of diagnosis becomes very important. You mentioned the relevance and importance of family history. Do you find family history as being useful in differential diagnosis? And you do read about the family histories of bipolar disorder seen in schizophrenia patients and vice versa. So there's a lot of overlap there. So how much importance do you play to family history in terms of diagnosis, and also whether there are any other indicators that you think that might be helpful in the differential diagnosis of affective versus non-affective psychosis?
Yeah, that's a great question. I think probably my answers are all going to be disappointing in the sense that, like, yes, that part of the talk, and unfortunately, yes, like maybe not perfectly aimed at this audience. That part of the talk, right, about people with like, yep, they don't definitively have a psychotic disorder or bipolar disorder, but you're worried something is brewing. How do we anticipate it? But yeah, I get your exact question. For people who are treating, like, yep, someone they had looks like a manic episode, and now we're trying to figure out, is it bipolar disorder, or is it going to become like, yep, psychosis independent of mood episodes, like basically towards a non-affective schizoaffective disorder, schizophrenia diagnosis. What I would say is, I don't think family history has ever helped me, like in terms of figuring that out. I would not say that it can't be helpful. There may be people on this call who really can speak to that. I don't see it. Like, I actually think that like these things, they all run in families so closely together that like someone presenting with a manic episode who has schizophrenia in their family, like I think what happens 60 years down the road really, it really could be bipolar, just as easily be bipolar disorder with no non-affective psychosis, or really could progress to become, a more chronic psychotic picture. I have not found family history all that helpful in thinking about that. The second part of your question, and again, I'm gonna confess, like, I just don't think I'm the pro to do this. Like, so are there certain things about someone's first presentation that make you think about bipolar disorder versus a schizophrenia, schizoaffective disorder? I think there are. I don't know how many of them are really stand up, to the test of time and so on. Like, I think I've been taught a few things, basically about like what did things look like before the first break in terms of cognitive decline, in terms of like social functioning, things like that. I've had a couple people tell me that, like, looking at what happened before that episode, like if you see more and more of that, it starts to look more like a non-affective schizophrenia, schizoaffective future. That's what I was taught. I just don't know I don't know if it really stands up.
I think that point, Roscoe, is very important, of pre-morbid cognitive impairment. There's study after study showing in birth cohort studies that those who have cognitive deficits early on in childhood or adolescence, when followed up, they're like several times more likely to end up with a diagnosis of schizophrenia as opposed to bipolar disorder. And in fact, studies seem to suggest that the pre-morbid cognitive ability of bipolar disorder, if anything, may be even better than normal. So that may be an important distinguishing factor. That's one thing. The other thing, in terms of family history, it would be good to have your thoughts on this, is this literature on family history of lithium response itself being a predictor of lithium response. You have some thoughts on that?
Yeah. I think I would say this, like, I believe in that. Like, I actually think that and for the wider audience, like there are a few like really interesting papers out there that are like entirely focused like on the genetics of lithium response, and how like that really seems to be that that factor, right, seems to be something that is, independent, right, of bipolar disorder risk and schizophrenia risk and so on, and genetics. It really, there's evidence it really can run in families. I would say this. I absolutely am a believer in it. I feel like it's very hard for me to remember. This does happen. Very hard for me the last time I sat across from someone where we knew it was bipolar disorder, lithium was an option, they were interested, and also they had a family member with bipolar disorder who was so open and forthcoming about their diagnosis and treatment that the patient in front of me could tell me, yes, lithium saved that person's life, or no, like lithium, all it did was, kind of horrible, like, basically like just water retention, stuff like that. I can't, excuse me. I don't remember. Yeah, speaking of water, well, wrong way. Sorry. That scenario hasn't come up in the clinic very
You
much
need
for
some
me.
water.
Yeah. Next question.
Well, I can say I know the hand just went down, but Sid, thank you for waiting. Do you still have a question you want to bring up?
Yeah, sure. Thank you so much for this talk. This is really helpful. I am a PGY4 resident at Cambridge Health Alliance, working on the first episode team there. You mentioned that for bipolar, medications aren't the only treatment. Could you talk more about like what else you would want to see in systems approach treatment to bipolar? Is there anything like coordinated specialty care for severe bipolar?
Yeah. So the short answer, okay. So I'd say this. The short answer is absolutely, right? I've seen, like, I've not participated myself in a bipolar specific CSC. They exist, like, out there, like, I don't know, maybe someone on the call can tell me. I think Michigan, right, like is home to, like, it's a home to basically a kind of a school, like how to do that. Maybe Pittsburgh. I don't know. Kesh, you'd have to tell me about that. The short version, I'm aware of that. I would also say I, like most people, don't practice in a place where there is a bipolar specific CSC kind of program set up and running. So or that I'm aware of, I should say that. Like, I would love to have good news that someone has that running up in Boston. So the short version, I don't know basically what are like the best, the tested true best principles for a bipolar specific CSC, other than the fact that they exist. There's data backing up like their efficacy absolutely out there. When I talk about, like, I don't think of, medication as an adequate treatment for this disorder, I'm not even thinking about like of really cool stuff like coordinated specialty care. I am simply thinking of basically people needing to be in individual therapy, like, it happens frequently. Their families need to be involved. Ideally, their families are basically involved in a way that's like is two things, both psychoeducation about the illness and also support, right? Like through organizations like NAMI. I am thinking about, basically that when mood episodes happen, when things happen, we prescribers, so I can, often we reach for medication, increases as a way of handling things, or medication switches. That is tough, like, to put up with, like, from a patient perspective. So accessing things like individual outpatient treatment programs, so on, more often, like having, those places, knowing how to reach out and make referrals, knowing which ones can get a patient in, like without an 8-week wait, like having all those things at your disposal. I'm thinking of simple stuff like that, not even like coordinated specialty care. I think all of those things are like really important. And the last thing I'll throw in here, and sorry again for the soapbox. I think this illness, we don't have the tools we need pharmacologically to treat this illness. Like, we just don't. Like, the situation broadly is disappointing, and I hope for things to get better and better and better. That said, I have sat with many people with bipolar disorder for whom we cannot get a great handle on treating mood episodes. We can't get them to a place where they don't happen. But the thing that's also really impairing in their life is something else too, an anxiety disorder, or a substance use disorder or something like that. A bunch of things. I would never call them low-hanging fruit, but if you can't really get a good handle, basically on treating treating this person as like they have bipolar disorder, and that's what I'm going to focus on, getting substance use out of their life, successfully treating anxiety disorders, using CBT or other interventions. I think those things actually can make a huge difference for a person without piling on more and more and different medications for the mood disorder. Okay, I hope that's helpful.
Yeah, if
I
I
wonder,
may,
Susan,
I may
if you can say
add
more about. Oh, go ahead, Cash.
Yeah, if I may add my 2 cents on this, and Roscoe, you have heard me say this before. Bipolar disorder and schizophrenia are so similar biologically, symptomatologically, and they overlap so much in terms of the treatment response, and even the genetics, that it makes no sense to make a distinction between coordinated specialty care services for affective and non-affective disorders. The therapeutic elements needed for bipolar disorder are very much similar to what we think of for non-affective psychotic disorders as well. But at the same time, it's important for clinicians to know the distinctions, because there are some variations in pharmacology and psychotherapy, the focal points that we need to think through between the 2 disorders. And of course, the outcomes, the natural course, and the prognosis to some extent do differ, and that gets into the conversations that we have with patients and families.
Yeah, Susan, can you say a little bit about the adaptations that you guys have been making in Navigate?
Sorry.
Not to put you on the spot.
I'm trying. No, that's okay. I was just trying to get off mute. I'm usually trying to get on mute rather than off. But Navigate is working on an adaptation of their program in order to be more focused, to have a treatment program specifically focused on bipolar. And
that's great.
What we found is that we really needed different different psychosocial, different education. We know that people will benefit from education about the illness. We want that education to be focused on bipolar. We know that people benefit from medication with bipolar. We want our psychiatric medication training to be about that. We know families benefit, but we also know that they need information about bipolar. What are the recommendations for how to support their loved one? And we know that they're equally eager to get back on track and work in school. And that's why we think they still need supported employment and education. So having the same components as our Navigate for schizophrenia, it's just that things need to be a bit fine-tuned so that, for example, education about bipolar should include more things about sleep. That's how sleep affects bipolar disorder. More things about getting more structure in your life, like a routine. More things about that address that sometimes mania can be attractive. That some people enjoy when they've had some of their experiences with being with having a manic episode and kind of laying it out. What are the consequences, though? It's like it's not as cut and dried as most people just do not like a psychotic episode. That is not attractive. But sometimes the mania is hard to give up. So all those things we think need to be put together into a coordinated specialty care package, just like we did for schizophrenia. In the one program I'm more familiar with would be, is it Gold? It's actually in Colorado, where it's multifamily group, it's a family-focused approach to bipolar disorder. I'm blocking on the name of the guy, but it has to do again with education, teaching the families how to communicate better around the illness and problem solving. Yeah. So, but right now the materials have been developed. We're using them to seek like feasibility. Are these materials usable by the clients and their families? Do they find them helpful? And then we're going to try it out and see if we can have a couple of sites that are willing to use it and give us feedback about it. Because just like Roscoe was talking, we don't want to just say, oh, this works in one situation, or we think this is going to work. We'd like to have a track record. And there's possibly a program in Florida that's willing to do that with us. So that's where we're at. We're going to call it Stride, because we did not want to, we wanted to distinguish it from Navigate. And I think maybe those initial stand.
Yeah, good.
I'm sorry?
It wasn't me. I think someone accidentally unmuted.
Got it. Yeah. But anyway, that's where we're at with that. And we're really eager to have something that addresses this very large group of young people who struggle with bipolar disorder, and for which I wish there was a similar to the RAISE program where they actually put money, NIMH would put money into investigating and to developing those materials. But in the meantime, we've done what we can, and we'll see when it's ready to roll out. I'll be happy to explain more about it.
Eagerly await that. Because even what I just described, right? Absolute patchwork of like basically, okay, you people, you family go to NAMI, you individual, this therapist that it's no fun, right? Trying to coordinate all those pieces together. And I mean, this is a principle. This entire call is organized on that principle that like it's miserable trying to just assemble the parts together. So I could not.
Having a team that's already set up for that.
Yeah, I could not be more excited about that program. So thank you.
Oh, Washington State's going to implement Stride, Eric Walker is saying. That's fantastic. I believe, was Piper out there training for that recently? Eric might know.
She will be starting training with us next week. I believe we have our first overview, and then in August we will be having her come out, and she'll be training a few of our teams in that.
That's awesome. And so in Washington State, they have a really strong network of Navigate programs for psychosis related to schizophrenia. And so your folks are already trained in how to do like individual resiliency training and family work. It's like retooling it for those teams so that they can also provide a comprehensive and a really coordinated approach for the persons with bipolar as well. Cami, thank you so much for reminding me that Piper was going to be training on that. Piper's in Minnesota, and she's does a lot with individual resiliency training, and that was one of the first manuals we took a look at to retool. Many more changes than I would have thought were needed. Oh, and Kathy Rizzo just came on. Kathy, we're working on helping you to be able to do this, right? You're thinking of doing Stride? Kathy's in Orlando. Yes. Oh, great. Okay.
Yeah, maybe I'll read Kathy's question out loud for the folks who can't see the chat. But she also asked, what do you think about the potential clinical benefits of lithium orotate versus lithium carbonate for bipolar in the future?
Oh, yeah. Okay. Actually, so I may not to follow up with the question. Lithium orotate, tell me if I'm getting it right, because I think it's basically formulation of lithium were basically much smaller dosages in terms of milligrams, or associate like higher what can I say, CSF concentrations, like basically getting some sort of a ratio, right, which is like much fewer systemic side effects, right? Fewer side effects that make it intolerable, and ideally keeping the same like kind of brain concentration that gets you a therapeutic effect. So this short, and also, if I'm remembering this correctly, lithium orotate, it's the dosages we're talking about. Like I've seen it for sale, right? Basically, in like in nutritional supplement, like basically in that kind of form. So And again, if I got any of it wrong, you correct
No,
me.
yes, you're
Yeah.
you're along the lines of what I'm thinking.
Yeah.
I was more looking for like maybe research that's perhaps up and coming because it is being used as a supplement, potentially has benefits clinically.
Yes, yeah. So here's what I would say. Aware of the research, actually aware of like two phases of research, right? Initial research, help me out, it's like 30 years ago or something like that. Basically, like people aware of this, tried it out, and the concerns about toxic, so not the usual lithium toxicity, but like cardiac toxicity, right? Like that was like basically an arrhythmia.
Yeah, or renal
Yeah.
something with renal.
Yeah, that was the big limiting factor. And then like, and that research just like basically just stopped, right? Like for, I think, or I'm not a big history of science guy, but my understanding is really kind of came to a halt because of that exact, set of health concerns, which is not something we associate with like, exactly lithium, carbonate. All I can say is this. I do know that basically that line of research of trying to figure that out, like, is there a way to prescribe, lithium orotate? I've seen a trial done somewhat recently, and it was something like a combination of that medication with something else to help prevent like an arrhythmia. I've seen that done in like tiny trials, and I know people are pursuing this like in a kind of bench research way to basically, ask a question like, is there a way to capture lithium orotate's ability to get into the brain without the side effects we associate with lithium for bipolar disorder, and also without that kind of like again, I think arrhythmia. I'm aware of it as a field of research, and I simply cannot tell if that's something that is it's going to be like a cool story, like, yes, like we rediscovered it and we figured out how to prescribe it safely, or if it's one of these things that exists as like a legend that like, yes, could be great and never moves forward. Like, I'm sorry, I don't have more to say. Sorry, it's a long way of saying I'm aware of it, and like I cannot tell if that's going to be a cool thing or
Hopefully it will. Who knows? But yeah, thank you.
Yeah, the cutesy phrase someone once taught me was like, so and so, like in this case, lithium orotate is like the treatment of the future, and it always will be, which is a depressing way to think of it. It never quite makes it into prime time. We'll find out. It's a fun story though, so if anyone, it's a Google search away, worth looking into. So yeah, that's fun. All right. Well, thank you all for having me. Like, I'm really very honored. Wait, is it okay for me to, am I wrapping up, Kelsey?
Yeah, we have one more question that we just got, but I think happy to have this be the last question to give folks some time.
Yeah. Right. Clients dependent on cannabis, a difficult aspect of sleep, right? So like, it's okay, maybe what I would say is this, like, it's probably the best thing I can do is like for this question, and also something that happens all the time in clinic is acknowledge, I don't know, acknowledge the benefit, acknowledge the dilemma, right? Which is, I spend so much time like, telling people, sleep, got to get sleep. Sleep's important. Like, let me know if you're not sleeping, sleep. And then someone comes to me like, I found something that it really helps with sleep. I don't think you'll like to hear the punchline. And because it's like, yes, using like, substantial like, amount of cannabis at night to help fall asleep or treat anxiety so that they can fall asleep, whatever the mechanism. I think the best I could do is just, as I said, acknowledge it, with the person, like, I get it. In some ways you're doing exactly what like I want in terms of, treating your sleep as like sacrosanct. On the other hand, this way of doing it, right, through cannabis use, like, especially in this population. So on this call, right, talking about like not just bipolar disorder broadly, but bipolar disorder where like there's been psychosis in the past and you're worried about psychosis in the future. I think inevitably I acknowledge its utility and acknowledge like, I get it, I get why you do it. And also, how do we replace this with something else, right? Like, and the something else then becomes it just becomes a really hard question, because like, yep, we could talk about sedating medications, but like, if that would have worked, if that was tolerable, we would already be doing it. Like, you know what I mean? If like 600 milligrams of Seroquel helped someone fall asleep and they weren't horribly groggy the next day, I bet they'd be doing that instead of cannabis. It's a long way of me saying it's not a simple answer to it. Like, I think it's a bad idea, right? You know, it's a bad idea that people gravitate to because it pays off and it works, you know, but I would try to move people away from it, simply because I think it does really lower the bar to having psychosis. And I've worked with individuals for whom like THC content or unexpectedly high THC content has led as far as like the straight to the emergency room on repeated occasions, in a way which is like frightening and precipitous. And so I'm a fan of trying to keep it out of people's lives if at all possible.
Yeah, great question. So yeah. Oh, sorry, reading other folks in the chat. Thanks for giving some follow-up on that, Daniel. And yeah, I'll also bring folks' attention to we have an evaluation form for all of our talks, so please do follow that link before heading out. But really appreciate it, Roscoe. I feel like this has been super comprehensive. Definitely happy to have the slides to share with folks after as a resource. But yeah, thanks so much for coming on, and thanks everyone for your really great questions, and Susan for speaking on the spot.
Thank you very much, Dr.